So today we're moving into disorders of the lower gastrointestinal tract. And as we work through these conditions, I don't want you to focus only on memorizing lists of signs and symptoms. Remember, I want you to think about what's actually happening in the bowel and how that explains what we're seeing. So a lot of lower GI disorders can initially look very similar. Patients may present with abdominal pain, changes in bowel habits, nausea, vomiting, distension, or changes in their stool. And our jobs as nurses is to really recognize the patterns that will help us determine what might be happening, how sick the patient is, and what needs our attention first. So as we go through each disorder, we're going to be consistently asking ourselves what's happening physiologically, what would I expect to see in this patient, what findings would concern me, what complications am I trying to prevent or recognize early, what's my priority nursing assessment or intervention. And so you've already have a foundation knowledge of GI anatomy and assessment. So we're going to build on that and focus much more on recognition, prioritization, and nursing management when we get to class. One important theme throughout this lecture is that a change in abdominal findings can be significant. So a patient who suddenly develops severe pain, rigidity, fever, tachycardia, hypotension, or other signs of deterioration should immediately make us think beyond the original GI diagnosis and really consider complications such as an obstruction, maybe perforation, peritonitis, hemorrhage, or sepsis. So I'm not going to spend a lot of time on these objectives because you're already really familiar with how we're approaching clinical judgment in this course. But for this unit, we're going to focus on lower GI disorders and build on what you already know about GI assessment, as I said. These are really the four things I want you to take away from this content is first, be able to recognize what is normal versus abnormal when assessing the abdomen and the GI system. Secondly, be able to differentiate between disorders that can look very similar. So like I said, a lot of these patients are going to present with some combination of abdominal pain, diarrhea, constipation, distension, nausea, or changes in stool. So we'll focus on the findings that help us distinguish one problem from another. Third, understanding the major treatments and nursing management. So rather than memorizing every possible intervention, we want to think about what we are trying to accomplish for our patient. And finally, and probably most importantly, knowing the major complications. So with lower GI disorders, I want you to recognize when something has progressed from an expected finding to something potentially serious, such as obstruction, perforation, peritonitis, hemorrhage, or sepsis. I always tell my students perforation, peritonitis, sepsis, and death. And we'll talk about that a little bit more in class. So as we move through these disorders, we're spending less time memorizing our lists, more time connecting the disease, what you're seeing in the patient, and what we're going to do about it. This is our agenda. So we're going to do a quick overview of the GI system. We're going to talk about diverticulitis versus diverticulosis, go into IBS, bowel obstruction, abdominal, acute abdomen, ulcerative colitis, Crohn's disease, and we'll end on ostomy care. So before we get into the individual disorders, let's review what the intestines are actually responsible for, because when something goes wrong, the patient's symptoms often make much more sense if we understand the normal function first. So starting with the small intestine, this is where the majority of digestion and nutrient absorption takes place. So the small intestine, it's divided into the duodenum, jejunum, and ileum. So as chyme leaves the stomach and enters the duodenum, it mixes with bile and pancreatic enzymes, which continue the digestive process. And as that material travels through the jejunum and ileum, nutrients, vitamins, minerals, and a significant amount of fluid are absorbed into the circulation. The intestinal lining has villi and microvilli, which dramatically increase the surface area available for absorption. And that's going to become clinically important when we talk about disorders that damage or inflame the small intestine. So if that absorptive surface isn't functioning appropriately, the patient can then develop malabsorption, diarrhea, nutritional deficiencies, and weight loss. The ileum, it also has some particularly important functions. It's responsible for absorption of vitamin B12 and bile salts. So later, if you encounter a patient who has disease involving the terminal ileum or has had part of the ileum surgically removed, we want to think beyond bowel movements. We may also need to think about nutritional consequences. And then intestinal contents move through the ileocecal valve into the large intestine. And the primary job of the large intestine, or the colon, isn't really digestion. Its major functions are to absorb water and electrolytes, form and store feces, and eventually eliminate waste. The colon includes the ascending, transverse, descending, and sigmoid colon, followed by the rectum and anus. And as intestinal contents travel through the colon, water continues to be removed. So what starts as relatively liquid gradually becomes more solid. And this helps explain why motility really matters so much in our GI tract. So if intestinal contents move through the colon too quickly, there isn't enough time to reabsorb water, and so the patient develops diarrhea. And if it's significant or prolonged, we start worrying about fluid volume deficit and electrolyte abnormalities. On the other hand, if contents move too slowly, the colon continues absorbing water. The stool becomes increasingly dry and hard, which contributes to constipation and potentially fecal impaction. We're also going to talk about disorders where movement through the intestine becomes partially or completely blocked. So when that happens, fluid, gas, and intestinal contents accumulate proximal to the obstruction. And that's why patients can develop abdominal distension, pain, nausea, vomiting, and changes in bowel function. And if the obstruction compromises blood supply to the bowel, now we're dealing with a much more serious situation. Another important function of the lower GI tract involves the intestinal microbiome. The colon contains a tremendous number of bacteria, and many are beneficial and contribute to normal intestinal function, including metabolism of certain substances and production of some vitamins, but disruption of that normal balance, for example, following antibiotic therapy, can contribute to disease. And finally, remember that the GI tract has a very rich blood supply. The intestinal tissue needs adequate perfusion, just like every other organ. And if blood flow becomes compromised, bowel tissue can become ischemic and eventually necrotic. So as we move through these disorders, think about a few basic mechanisms. Is there inflammation? Is something obstructed? Is motility too fast or too slow? Is absorption impaired? Is there infection, or is blood flow compromised? If you can identify what's going wrong with normal intestinal function, many of the patient's manifestations become much easier to predict. So before we talk about manifestations and management, I want to make sure the difference between diverticulosis and diverticulitis is very clear, because these terms are sometimes used interchangeably, but they're not the same condition. So let's start with diverticulosis. So diverticula, these are small sac-like outpouchings that develop in the wall of the colon. And they occur when the mucosa and submucosa push outward through the weaker areas of the muscular wall. And it's often where blood vessels penetrate the colon. So we want to think about increased pressure inside of the colon. Historically, a low-fiber diet and constipation have been associated with diverticular disease because smaller, harder stools may require greater pressure to move through the colon. But we now know the development of diverticula is likely more complex than fiber intake alone. So age, genetics, bowel motility, obesity, smoking, and other factors may contribute. So the sigmoid colon is a particularly common location for this to occur. The lumen is then narrower here, and greater pressure may be generated as stool is moved through toward the rectum. And the important distinction is that the diverticulosis, those pouches exist, but they're not inflamed and they're not infected. They're just there. Many patients with diverticulosis have absolutely no symptoms. In fact, a patient may find out that they have diverticulosis because they undergo a colonoscopy or imaging for an entirely different reason. So when you see the suffix osis, we want to think about the presence of the diverticula. Now let's move to diverticulitis. This is when one or more of those diverticula becomes inflamed, sometimes with infection. And the exact mechanism isn't always simply stool gets stuck in the pouch, but obstruction of the diverticulum and changes in the local environment can contribute to inflammation. And once inflammation develops, the surrounding bowel tissue can also become involved. So now the clinical picture has changed. So instead of an asymptomatic patient with diverticulosis, the patient with acute diverticulitis is much more likely to present with abdominal pain, classically in the left lower quadrant, along with tenderness, fever, and possibly leukocytosis. They may also experience nausea and changes in bowel habits. And so why do we see pain in the left lower quadrant? Remember where the sigmoid colon sits. And this is why. So in Western populations, diverticular disease, it frequently involves the sigmoid colon. So inflammation there often produces that left lower quadrant pain. And the biggest reason we care about diverticulitis is that it can progress. The inflamed diverticulum can develop a microperforation or even a larger perforation. And once intestinal contents or bacteria escape outside the bowel, the patient can then develop an abscess or peritonitis, which can be very dangerous. Inflammation also creates abnormal connections between structures. These are called fistulas. For example, a fistula can form between the colon and bladder. So if a patient with a history of diverticular disease begins experiencing recurrent urinary infections or reports air in the urine, that would be an unusual finding that then deserves further evaluation. Severe infection can ultimately progress to sepsis. So I want you to be thinking about these as a progression. So we can go from diverticulosis to diverticulitis. We have pouches present in osis. Now they're inflamed in itis. And once inflammation occurs, our concern then shifts upward, whether the disease is uncomplicated or whether the patient is developing a perforation, abscess, peritonitis, obstruction, a fistula, or systemic infection. And one last distinction that's important for practice, a patient with known diverticulosis does not automatically have diverticulitis. So the presence of diverticula alone doesn't mean that the patient needs treatment for an acute inflammatory process. So when you hear these terms, don't just think diverticular disease. We want to ask, are the diverticula simply there, or are they currently inflamed? And that distinction is going to determine what we're going to see clinically and how the patient is managed. So now that we've separated diverticulosis from diverticulitis, let's look at who is at risk. So starting with risk factors, age is one of the strongest. Diverticula become increasingly common as people get older because there are changes in the strength and elasticity of the colon wall over time. You'll often see a low fiber diet listed as a risk factor. The traditional explanation is that less fiber contributes to smaller, harder stools, which may require the colon to generate greater pressure to move stool forward. But remember that diverticular disease is multifactorial, so we don't want to reduce it to simply this patient didn't eat enough fiber. Other factors associated with diverticular disease or its complications include obesity, physical inactivity, smoking, family history, and NSAID use. NSAIDs are particularly worth recognizing because they're associated with increased risk of complications such as diverticular bleeding and perforation. Now let's compare what these patients actually look like. So with diverticulosis, like I said, most patients don't look sick at all because they're usually asymptomatic. They may have some non-specific symptoms, maybe bloating, constipation, some mild cramping, or changes in bowel habits, but many people don't know that they have diverticula until they're discovered incidentally. Comparing that with acute diverticulitis, the classic presentation I want you to recognize is that left lower quadrant abdominal pain and tenderness. It's often accompanied by fever and an elevated white blood cell count, so that leukocytosis. The left lower quadrant location makes sense, again, because that sigmoid colon, that's most commonly affected. Patients can also experience nausea, vomiting, decreased appetite, bloating, and changes in bowel habits. Some patients become constipated while others may have diarrhea. But pay attention to what happens as the findings become more severe. So if I tell you that the patient has left lower quadrant pain and a low-grade fever, that fits with uncomplicated diverticulitis. But if I tell you that the patient has increasing pain, guarding, rebound tenderness, abdominal rigidity, tachycardia, hypotension, or appears systemically ill, you're thinking should really change, right? Now we're concerned that the inflammation may have progressed to something like perforation, abscess formation, peritonitis, or sepsis. For diagnostics, we're going to start with the history, physical exam, and lab findings. A CBC, complete blood count, may show leukocytosis because, again, we're dealing with an inflammatory process. And then inflammatory markers such as CRP may also be elevated. This is a non-specific finding. And depending on how ill the patient is, additional lab studies may be needed to evaluate hydration status, renal function, electrolyte abnormalities, or systemic infection. But if we suspect acute diverticulitis, the key diagnostic study is typically a CT of the abdomen and pelvis. And this is going to help us answer two questions. Does this patient have diverticulitis? And equally important, is there a complication? So we're looking at the bowel wall for inflammation and surrounding inflammatory changes like an abscess, perforation, obstruction, or fistula. Now notice the bottom of the slide is listed colonoscopy. So a colonoscopy may be useful later, but we generally do not perform a colonoscopy during an acute episode of diverticulitis. And I want you to think about why. So the bowel is already actively inflamed and it's potentially very fragile. So during a colonoscopy, we're really introducing the scope and we're inflating the colon. And in an actively inflamed bowel, we don't want to unnecessarily increase the risk of perforation. So instead, when indicated, a colonoscopy is performed after the acute inflammation has resolved. So this would be several weeks later. And this allows the provider to evaluate the colon and exclude other pathology, particularly colorectal malignancy, when appropriate. So if you're given a patient with suspected acute diverticulitis and you're choosing between a CT scan and a colonoscopy, that CT scan is going to be the appropriate study during that acute episode. Next, we're going to talk about irritable bowel syndrome, or IBS. And the first thing I want you to understand is that IBS is very different from inflammatory bowel diseases we'll discuss. So IBS, it's considered a disorder of gut-brain interaction, sometimes described as functional GI disorder. And that means the patient can have very real and sometimes significant symptoms, but we're not seeing the type of structural inflammation, ulceration, or tissue destruction that we do see with Crohn's disease or ulcerative colitis. So if we performed imaging or looked at the bowel itself, we wouldn't expect to see the obvious tissue damage that occurs with inflammatory bowel disease. So what's actually happening? IBS involves altered communication between the GI tract and the central nervous system. So the intestines have their own extensive nervous system, the enteric nervous system, and there's constant communication occurring between the gut and the brain. And in IBS, that communication and regulation can become altered. So two concepts are especially important here: altered motility and visceral hypersensitivity. So with altered motility, the bowel may move contents too quickly or too slowly. And if motility is increased, intestinal contents move through more rapidly, which can contribute to diarrhea. If motility is decreased, contents remain in the colon longer, more water is absorbed, and the patient develops constipation. In some patients, this may alternate between the two. And that's why IBS is often categorized as IBS-D, which is predominantly diarrhea, D for the diarrhea, IBS-C, predominantly constipation, and IBS-M, which is mixed bowel habits. The other important concept is visceral hypersensitivity. So these patients can have an increased sensitivity to normal intestinal sensations. Things like intestinal distension or gas that another person might barely notice can produce significant discomfort or cramping with someone who has IBS. So the patient's pain, it's absolutely real. We don't necessarily see tissue damage that explains the severity of that pain, but it's still very real. And what about stress? So stress and anxiety are commonly associated with IBS, but be careful with how you interpret that. So IBS is not simply caused by anxiety, and we don't want to tell a patient that their symptoms are just stress. So instead, think about the gut-brain connection. Psychological stress can influence intestinal motility, secretion, and sensitivity, and therefore trigger or worsen symptoms in someone who is susceptible. Some patients also develop IBS following an episode of gastroenteritis, and you'll sometimes hear this called post-infectious IBS. Diet can also trigger symptoms. Certain patients notice symptoms after fatty foods, caffeine, alcohol, or foods containing fermentable carbohydrates known as FODMAPs. But triggers can vary significantly between individuals. So what is our patients going to look like? So the hallmark manifestation is recurrent abdominal pain associated with changes in bowel habits. So patients may describe cramping, bloating, gas, diarrhea, constipation, or alternating episodes of both. The abdominal discomfort is often related to defecation. Some patients feel better after having a bowel movement, although that's not true for everyone. Another characteristic is that IBS tends to be chronic and reoccurrent. Symptoms may flare for a period of time, they may improve and then return. And mucus can sometimes appear in the stool. But an important distinction is that IBS should not cause intestinal bleeding, significant inflammation, or destruction of the bowel. That becomes a very important distinction when we're evaluating the patient. How is IBS diagnosed? So there isn't a blood test that comes back and says positive for IBS. Diagnosis is primarily clinical. It's based on patient's characteristic symptom pattern. It's often established using symptom criteria while evaluating whether another condition could better explain the presentation. And testing is individualized rather than automatically performing every test on every patient. So depending on the presentation, providers may order lab studies, celiac testing, stool studies, or colonoscopy. What we're particularly interested in are alarm or red flag findings. So looking at the bottom of this slide, if a patient is telling me I've had abdominal cramping and alternating constipation and diarrhea for several years and it tends to flare with certain foods or periods of stress, that could fit IBS. But now imagine we're having a patient say, I've lost 15 pounds without even trying, I've had blood in my stool, and I've been running fevers. So that's probably not attributing to IBS. It's something that we need to dive a little bit deeper into. I want to say things like GI bleeding, unexplained weight loss, anemia, fever, certain family histories, or a concerning new symptom pattern, that really should prompt further evaluation for another underlying condition.